Let us begin with a story you will hear many times in your nursing career. Meet Mr. Jones, a 68-year-old man who comes to the clinic looking a bit weary. He tells you that sleep has become a luxury he can no longer afford. He is waking up to urinate 3, sometimes 4 times every single night. When he does go, he finds himself standing there for what feels like an eternity, needing to push just to get the stream started. Even after he finishes, he never truly feels like his bladder is empty. To cope, he avoids water after dinner, hoping for uninterrupted rest, but it has only left him tired and drained during the day. His urine looks normal, no fever and no pain, just persistent, frustrating disruption. This clinical picture is a classic presentation that every nurse preparing for the NCLEX must recognize. While the name sounds complicated, the story is incredibly common among older men. As a nurse, you are on the front lines of identifying these symptoms and guiding next steps. Your role is not just to observe but to understand the entire care pathway. This mini masterclass is designed to equip you with that knowledge. We will walk through the cause of BPH, the essential assessments you need to perform, the tests that confirm the diagnosis, and the full spectrum of care from medications to surgery. Our goal: build your confidence so you never miss a BPH question again. We will break down this complex topic into simple, manageable pieces. To truly grasp BPH, we must first understand the anatomy involved. The prostate is a small, walnut-sized gland that is part of the male reproductive system. Its location is critically important. It sits just below the bladder and completely surrounds the urethra, which is the tube that carries urine from the bladder out of the body. The prostate's main function is to produce some of the fluid that nourishes and transports sperm. In a young man, the prostate is small and causes no issues with urination. However, as a man ages, this gland has a natural tendency to grow larger. This non-cancerous enlargement is what we call benign prostatic hyperplasia. Benign means this growth is not prostate cancer. The problem with BPH is purely mechanical. Imagine a garden hose with a clamp around it. Tighten the clamp, the flow of water weakens and becomes restricted. This is precisely what happens in BPH. The enlarging prostate narrows the urethra, forcing the bladder to work harder and causing disruptive urinary symptoms. Your role as a nurse begins with a sharp and focused assessment. When a patient like Mr. Jones presents with urinary complaints, you must know which questions to ask and what signs to look for. The symptoms of BPH can be divided into two main categories: obstructive symptoms, irritative symptoms. Obstructive, weak or diminished urinary stream. Obstructive, difficulty or hesitancy in starting urination. Obstructive, straining or pushing to get the urine out. Feeling that the bladder is never completely empty. Post-void, dribbling or leakage. Irritative, urinary frequency. Irritative, urinary urgency. Irritative, nocturia, waking at night to urinate. Nighttime urination causes daytime fatigue and reduced quality of life. Ask about all these symptoms to understand the impact. Beyond history, the physical assessment gives vital clues. Start with a full set of vital signs. A fever could indicate a urinary tract infection mimicking or coexisting with BPH. Measure fluid intake and urinary output to quantify the problem. If available, perform a post-void residual check with a bladder scanner. Diagnostic detectives, key tests for confirming BPH. Once your assessment raises suspicion for BPH, a series of diagnostic tests confirm the diagnosis, rule out other conditions, and determine severity. As a nurse, be familiar with these tests, know why they are ordered, and how to prepare the patient. The first and most basic test is a urinalysis. A urine sample is examined to check for infection like white blood cells, blood or hematuria, and other abnormalities. If infection is suspected, order a urine culture to identify the bacteria and guide antibiotic treatment. Another critical test is the prostate-specific antigen or PSA. PSA is a protein from the prostate. Levels can rise with BPH. PSA can also be elevated due to prostate cancer, prostatitis, and even recent ejaculation. An elevated PSA is not definitive for cancer but signals the need for further investigation. Know your facility's PSA protocols and teach patients that PSA is one piece of the puzzle. For many men with mild to moderate BPH symptoms, medication is first line. You must know the two main drug classes, how they work, and what to watch for. The first class is the alpha blockers, tamsulosin, terazosin. These do not shrink the prostate itself, they relax smooth muscle cells in the prostate gland and at the bladder neck, widening the urethral opening and reducing obstruction. They work quickly, many feel better within days to a week, but systemic smooth muscle relaxation can drop blood pressure, causing dizziness, lightheadedness, even fainting. Orthostatic hypotension. Monitor blood pressure, especially when starting therapy. Teach patients to change position slowly, sit before standing. Other effects, nasal congestion and retrograde ejaculation, where semen enters the bladder instead of exiting. The second class is the 5-alpha reductase inhibitors, finasteride, dutasteride. They block 5-alpha reductase, preventing testosterone's conversion to DHT, lowering DHT in the prostate and shrinking the gland over months. Sexual side effects, decreased libido, erectile difficulty, reduced ejaculate volume. They reduce PSA by about 50%. Document for accurate screening and consider combination therapy for quick relief plus long-term shrinkage. While medications are a cornerstone, nursing care extends far beyond pills. Education and lifestyle changes improve symptoms and quality of life. Discuss fluid management. Fluid restriction can cause dehydration and concentrated urine, irritating the bladder and worsening symptoms. Encourage normal intake spaced through the day, but decrease fluids, caffeine and alcohol 2 to 3 hours before bedtime. Teach timed voiding every 2 to 3 hours. Use double voiding, wait a minute or two, then try again to empty more completely. Kegels can strengthen control and reduce urgency. Review meds. Decongestants like pseudoephedrine and anticholinergics can worsen retention. Collaborate to adjust. Prevent falls from nocturia. Add night lights, clear paths, and consider assistive devices or a bedside commode. When meds and lifestyle are not enough or complications arise, surgery is next. The gold standard, TURP, transurethral resection of the prostate. A resectoscope enters via the urethra. An electrical loop removes excess tissue, opening the channel. Newer options include HOLEP and green light laser with less bleeding and shorter recovery. Post-op, patients return with a large 3-way catheter for continuous bladder irrigation. CBI. One port inflates the balloon, one drains urine, the third irrigates with normal saline to prevent clots. Ensure the system runs smoothly and monitor urine color. It starts reddish pink, then lightens over 24-48 hours. Watch for hemorrhage. Bright red blood or many clots could indicate arterial bleeding. If output drops and pain rises, check for kinks and perform manual irrigation per protocol. Teach patients to call for fever, chills, severe pain, inability to urinate, or heavy bleeding. For the NCLEX, remember fan hertz, frequency, awakening at night, narrow stream, hesitancy, urgency, residual urine feeling, trouble starting, straining.